Welcome to the EADV podcast. In this episode, we explore the recent outbreak of Trichophyton mentagrophytes ITS genotype 7 infections among men who have sex with men in Paris and across Europe. Presented by Professor Carle Paul and leading mycologist Arnaud Jabet, assistant professor at Pitié-Salpêtrière University Hospital in Paris and first author of a key paper in JEADV's February issue, the discussion examines the sustained transmission, extended incubation period, and treatment challenges of this condition. The infection requires long-term systemic therapy as topical treatments are largely ineffective. But before we get into that,
did you see our latest call for papers? JEADV is excited to announce an open call for submissions on personalized medicine in dermatology. We welcome latest research on molecular and genomic approaches, microbiome analysis, AI-driven diagnostics, immunological profiling, and more. With this special issue, we aim to inspire further investigation and clinical implementation and address critical unmet needs in the field of dermatology. Don't miss out. Submit your paper by the JEADV Scholar One website by the 30th of April 2025. For more details and submission guidelines, visit the JEADV website and social media today.
The conversation also highlights the risk of skin-to-skin transmission, the need for hygienic precautions, and the increasing number of cases across Europe, including France, Italy, Spain, and Belgium, as well as in the US. The must-read article by Jabet and collaborators is the most comprehensive evaluation of this epidemic phenomenon to date. You can find the link to the article in the podcast description.
So, dear colleagues, it's my pleasure to be here with you today to discuss a very important paper from Arnaud Jabet and collaborators about an outbreak of Trichophyton mentagrophytes type 7 infection in men who have sex with men in Paris and also in Europe. Arnaud Jabet is assistant professor at the Pitié-Salpêtrière University Hospital in Paris. He's a mycologist and is the first author of this very important paper which describes this outbreak of Trichophyton mentagrophytes skin infection. And thanks for being here, Arnaud. This paper is the most comprehensive evaluation of this epidemic phenomenon, and I'd like you to give us some insight into this work. And first, how did you get the idea to perform the study and to report these cases? Can you tell us a little bit about the story behind it?
Yes, thank you for inviting me to this EADV podcast. Yes, we published a first paper in 2023 in Emerging Infectious Diseases about this topic, but we reported only 13 cases. It was a short series of TMVII infections in men who have sex with men in Paris. But it was unsure whether the transmission would be sustained over time, and as the case series was small, the knowledge about TM7 were limited regarding epidemiological, clinical, and therapeutical aspects. And moreover, we had the opportunity to detect these outbreak events, which allowed us to get new insights regarding incubation time, for instance, we could not have had with just sporadic cases.
Very good. So, can you summarize, maybe in a few sentences, the main findings of the paper for the dermatologist who is listening to us?
Yes. So, first point, we demonstrate that indeed the transmission is sustained in Paris area among men who have sex with men, with a clear risk of outbreak event, just as we describe in the paper. Second, our data suggests that the incubation period is probably longer than expected, with a median duration of incubation period in our series of 16 days, and it could be as long as 52 days. And moreover, our data suggests that this incubation period could also be at risk of transmission. Third, we demonstrate that the systemic treatment has to be prolonged for weeks. The median treatment duration in this series is about 6 weeks. And moreover, we saw also that topical treatment had very limited efficacy, with some patients developing more severe lesions under topical treatment alone. And finally, we also demonstrate that patients remain contagious during the first weeks of treatment, systemic and topical treatment. We had positive cultures up to 4 weeks after the beginning of the treatment.
That's a very important point. So it seems to be an infection that is difficult to treat, that requires long-term systemic treatment, and patients can contaminate other patients for weeks after the treatment is started. What I noticed in your paper is that the same person who was a tantric masseur contaminated, I think 17 or 16 or 17 other people, or even more. How did you realize that the same person contaminated so many people? How did you realize that?
We had a first patient who had lesions and a background which were evocative of TM7. But this man had no sexual relations in the last few weeks. But he had received a tantric massage. Tantric massage is full body skin to skin massage. And he called this masseur, and this masseur had just been diagnosed with dermatophytosis. And after that, we saw most of his clients who had difficulties to receive a diagnosis and to receive an appropriate treatment.
So the idea is that people have to be very careful with skin-to-skin massage. Huh?
Yes.
Can you tell us a little bit about the species Trichophyton mentagrophytes? Because we are aware of Trichophyton indotinea, which is a cause of resistant infection, especially resistant to terbinafine. So how does this species relate to Trichophyton indotinea, and how much evidence you have that they are resistant to antifungal agents?
Yes. So TM7, Trichophyton mentagrophytes ITS genotype 7, is not a species per se. It's a subpopulation inside this bigger cluster, which is Trichophyton mentagrophytes. And it can be identified by sequencing the ITS region, which is the main regions medical mycologists use to identify fungi. Trichophyton mentagrophytes is considered a zoophilic species, but this TM7 spread through interhuman contacts. So that's one specific point of this TM7. We search for TM7 among isolates from companion animals in France, and we found no TM7. So probably there is no animal reservoir of TM7 in France. What's the link between TM7 and Trichophyton indotinea? They are both part of the Trichophyton mentagrophytes species complex. In this complex, we find Trichophyton mentagrophytes, zoophilic species, Trichophyton indotinea, probably an anthropophilic species, even if we have some cases of animal infection, and Trichophyton interdigitale, which is also an anthropophilic species mostly responsible for feet infection. We have no evidence of terbinafine resistance for TM7 now, even if we have therapeutical difficulties with prolonged treatments and some recurrence of the infection in the patients.
So if there is no resistance to antifungals, do you believe the situation of the fungus deep in the follicular area is responsible for the failure of topical treatment?
Yes, clearly that's my hypothesis. In some patients, at the beginning of the disease, they have already these nodular lesions, but we also saw some patients who developed these nodular lesions under topical treatment, and that's probably why topical treatment is most of the time inefficient, and also why we have to treat longer.
Okay, so 6 weeks of terbinafine at the minimum. What is your recommendation for patients who are in contact with somebody who is affected by Trichophyton mentagrophytes type 7 infection? So what is your recommendation regarding the subjects who are in contact, either the family members or the people who have sexual contacts with somebody who is infected? What should we do?
Now, these subjects in contact with somebody who is infected by TM7 should be aware they could at some point develop similar lesions. But I think the key prevention messages are for the patients, the people who are infected by TM7. They should avoid close skin-to-skin contacts involving the region with tinea lesions, and they also should avoid to share towels or clothes. In the paper, we describe one case where the transmission was probably mediated by the sharing of towels.
Okay, so you should not share the towels or the clothes with other people. Now, when it comes to if we have a patient who has Trichophyton mentagrophytes infection, what are your recommendations regarding what they should do with the clothes, the towels, the linen, and the bed? Do they need specific decontamination measures? What is your recommendation?
What I recommend is to wash at 60 Celsius degree. That's my only recommendation.
Okay, 60 degrees.
Yes.
Washing of clothes, linen, and towels.
And that's probably enough to decontaminate.
Very good. Since the publication of your article, which should appear in the February issue of the JEADV, I have received many manuscripts. One manuscript from Italy. We have seen cases in Greece, in Spain, also in the United States. Since the publication of your paper, what is the status of this infection in Europe? Do you have any insight into the newer data?
No, we know that indeed there are cases in Italy, in New York. We already knew there were cases in Spain, in Belgium. Cases were also reported in Berlin. In France, we know that there are cases not only in Paris, but also in other cities in France. So probably the TM7 has spread everywhere and probably not yet been described locally in most places, but is probably already present.
And in terms of the delay to diagnosis? I know that since your paper was published, we saw a patient close to Toulouse who had nodular lesions on the buttocks, and the dermatologist actually did not make the diagnosis. Do you have an idea about the mean delay in the diagnosis in the patients?
Yes. In our 2 articles, the mean delay of between lesion onset and mycological sampling was about 1 month. And there were some patients who were misdiagnosed with inflammatory diseases such as psoriasis or bacterial infections, in particular for the lesion of the face, which are highly inflammatory and which can be confounded with bacterial infections.
Yes, I think we saw these cases in the paper from Italy, which will appear in the same issue, in the February issue of the JEADV.
Yes.
Thank you, Arnaud. I mean, it's a fantastic paper. It's really very useful for the clinicians. We need all to be aware of this new epidemic outbreak of Trichophyton mentagrophytes infection. With your insight, we knew a little bit more how to diagnose this, how to treat it. And diagnosis is easy even for mycology labs who don't have your expertise. You think that all mycology labs are able to establish the diagnosis?
Yes, probably the key message is performing mycological sampling. After that, the mycology lab will probably respond its Trichophyton mentagrophytes. This genotype can be a little bit difficult. Sometimes it may look like Trichophyton tonsurans, but yes, most of the lab won't say it's type 7 because they won't perform molecular characterization. But I think that's not a big deal. The most important thing is to make the diagnosis of the fungal infection.
Okay, so if you see inflammatory lesions of the buttocks or of the bird in males, do not hesitate to perform mycology examination, and then systemic treatment, long-term systemic treatment is important. Thank you, Arnaud. It was a fantastic podcast, and thanks for submitting your excellent work to the JEADV.
Thank you, Professor Paul, for inviting me to this podcast and offering us the opportunity to share about our article. Thank you.
Thank you for listening. And if you haven't already, please make sure you subscribe on Apple Podcasts, follow us on Spotify, or otherwise you can find us on any major podcast provider. We appreciate you joining us and look forward to presenting more interviews on other important topics. If you're a regular listener to our podcast, we would love to hear from you. Your feedback will help us improve the show and develop episodes that you're interested in hearing. To participate in the short survey, simply follow the link in the show notes of this episode. Thank you for your support. It means a lot. Until the next episode, take care of your skin.